Okay, we're here to talk about getting things done in healthcare and getting things done with patient advocates, both in terms of moving the system, in terms of advocating for policies, etc. Eric Cioè-Peña, you're the Vice President for Global Health at Northwell, a health delivery system in New York. Why the hell do they have a Vice President of Global Health, and what are you doing there?
So thank you. It's a pleasure to be here. I am the Vice President of Global Health. Northwell, really, for those of you that know us, we're New York's largest private healthcare system. We're also the largest private employer in New York. And we're a little bit different in terms of a health system. We like to think of ourselves as equal parts margin and mission. And our CEO always asks us to think big. And so as part of our mission and our community benefit, we really took the word community and blew it up and made it the global community. And I think I'm on the stage today because global health is really about advocacy at its heart. We don't go to countries and say we've got the solutions or the answers for problems. We go to countries and find stakeholders that are already doing great work, that already know a lot of the solutions to the local problems, and we help them advocate within their own government, within international companies, to get the attention and funds and resources that those issues deserve.
Great. But we're at this point where there's a real problem. We've had some scandals, frankly, on the telemedicine mental health side with overprescribing. We have a rollback on the telemedicine side, just when it's like, wait a second, I thought this was a way of expanding supply, not time to contract. How are we going to navigate this, and how do we get patients involved and point them in the right direction to make constructive suggestions?
Yeah. Sure. I mean, I think we have to give ourselves permission to fail. You know, we have a Ukraine telehealth program that we launched back in March of 2022, and I think we call it jokingly, it's on version 15 right now, because every time we'd start something, we'd have this idea of what the need would be, how we would meet the need. And then we realized we weren't meeting it. We weren't solving the problem yet. And you know, we have to give ourselves permission to try and try again. A lot of this stuff, when you're on the cutting edge, you're not going to get it right the first time. And the things where I've seen people kind of fail the most spectacularly is when they take an idea or a concept and they're not willing to accept that they're not meeting the demand that their client, their customer, their patient in front of them has. And so you have to be able to iterate and reiterate and learn from mistakes in a very quick way. And the agility to do that is where you're going to find the successes.
So can I push you for 1 second? Is it easier to fail in Ukraine than the United States? And if that's true, how do we make it easy and safe, as it were, in the United States to fail and fail up so we learn something and move on?
I mean, your point's well taken. It is, I was joking at an earlier talk today that it's easier to license people to practice telemedicine in Ukraine from New York than it is to license them in New Jersey. And I think that there are just regulatory challenges. There's a litigious environment that exists in the United States that that stifles a little bit of innovation in medicine. Many of the marginalized communities are sick of hearing lip service, people coming in and saying, we want to help, but not really being able to offer anything of substance. And so we've done a really good job at the local level doing community listening tours, where we go and visit a community like Little Guyana in Queens. We just started a listening tour as our program in Big Guyana, as I call it, has taken off. And part of it is hearing what the community members want. And some of their asks are tough. Some of their asks are not just like, we want a fare to check blood sugars. Like, those are the things that are plug and play and easy for us to do. They want better access to mental health care resources. That's what they asked us for. And we have a strained mental health care workforce. And to just speak to the federal advocacy and state advocacy, the reimbursement system in our country sucks. And we pay for the healthcare system that we want. And right now...
No, I don't think that's right. No one wants the healthcare system. Sorry. I mean, literally.
We pay for the healthcare system that we get.
Yes, that's true.
That's the problem, is that we wonder why we don't have access to mental health services. We don't pay for mental health services. You're never going to get great mental health services if the reimbursement sucks. Yeah. And so until we fix that fundamental inequity, talking about equity in any kind of other way is just lip service.
Yeah. You guys have a medical school, right?
We do, yeah.
How are you training and a lot of residency and internship programs, how are you training the future docs to think differently about working with advocacy groups, about working with these different communities?
I think there's a glimmer.
You're not responsible for that, I know,
but I think there's a glimmer of hope in that. In my interaction with the medical students, I teach global health at the medical school and at the nursing school and to residents. But I think that the younger generation of physicians get this a lot better than my generation and older physicians get about community engagement, community activism. They grew up in a very connected, different world. They grew up where Black Lives Matter has happened and was already a thing. And I think that the desire of them to be physician leaders that are part of these communities is already there. What we need to do as leaders is, I think, hopefully protect them from some of the indoctrination that happens in medicine, especially during residency, where a lot of that idealism is, beaten out of them by their clinical mentors. And so I think we as leaders need to allow that younger generation to say this isn't good enough. This isn't good enough, and we need to do better.
I think.
Where's the middle ground that you would like politicians and advocates to get to so we can make progress? We're not looking for nirvana. We're looking for progress in each one of your areas.
I would ask everyone in this audience to call your congressman and reauthorize PEPFAR. I think that one of the things about finding the middle ground, the two presidents in U.S. history.
Explain a word about where PEPFAR is at this moment.
The two presidents in U.S. history that have done the most for HIV and AIDS worldwide are Bill Clinton and George W. Bush, and not in that order.
Right.
And PEPFAR is a George W. Bush-initiated era event that is currently held up for reauthorization and refunding. And if we refund it, and I'm sure Chelsea Clinton's going to talk about this at her talk later today, if we refund it, we can end new incidents of HIV by 2030. And we've never been so close to doing it. And to pull the rug out right now and not reauthorize this very important public health measure, I think would be a disservice to humanity.
And I want to thank the panelists for a terrific panel.